chances are, you've got an orientation at the knee where he's trying to use the knee to push down into the ground. Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. That is delicious. Okay. Digging into Monday. Quick housekeeping. Going through the applications for the Intensive 14. The official announcement would be by July 8th. I'm hoping to get that done a little bit early. So those golden tickets might be going out a little bit earlier than expected. So be looking for those if you are one of those folks who applied. Let's dig into today's Q&A. This is with Anthony. Anthony happens to work with a friend of mine, Jeremy Pastor, who does a little cameo appearance in this video. If you don't know Jeremy, please follow him on Instagram. He does good things out east. So Anthony's working with a wide receiver coming off of an ACL. I think he's about 8 or 9 months post, still having some pain related issues. And we break down the chessboard. So if you've ever been confused about chessboards, this is going to be a really good one for you folks. Anthony does a great job, actually, of understanding what he has measured. We went through a little bit of a review of that. So again, it makes that useful for those of you who are unfamiliar with the narrow archetype, especially in really fast people, because it shows up in this chessboard. And then we go through some reasoning and some interventions and such. So again, I think breaking this down like we did is going to be really, really helpful for a lot of people. So thank you, Anthony, for this. If you would like to participate in a 15-minute consultation, please go to askbillhartman@gmail.com, askbillhartman@gmail.com, and put 15-minute consultation in the subject line, and we will arrange that at our mutual convenience. Everybody have an outstanding Monday, and I'll see you tomorrow. All right, we are recording. Clock has started. Anthony, what's your question?
Okay, so Bill, my question is, I'm working with a high school football player. He's a wide receiver. He had left ACL surgery in October. He was cleared in March by his PT, but he was still in pain and discomfort. He came to me about 2-3 weeks ago. His chessboard, he's a narrow ISA. His chessboard, the biggest thing that stands out to me is I see the magnified ER on the right side. I just want to go through my interpretation of what I think is going on, then you can kind of intervene. So what I believe is happening is on the left side, I believe he's in a late propulsive strategy on the left side, which is turning the sacrum and the spine to the right. And that's what's giving me my magnified ER. And I'm assuming the right side is more an early propulsive foot. And I just want to just confirm that from because when I test ER, is the spine just turning to me?
Yeah, real quick, because it's not on the chessboard. What does his left foot look like?
In terms of
he pronated?
Yeah, you could say it's a little more pronated. A
little more or a lot?
Honestly, I don't know.
Okay. So. Okay, you're gonna have to find out because it's probably gonna influence the strategies that you're gonna use. Get out of here!
I don't want to take away from his time. Just saying.
Hey, you're not allowed to be on this video, man. You're taking up valuable time. Okay, Jeremy's a good guy. All right, so let's you're on point. Okay, you're really going in the right direction. But let's look at a couple of things. So right away. Narrow bias, and this is typical. For most wide receivers, you're going to see the narrow bias. Okay, that alone is going to magnify the ER because of the orientation of sacrum and the innominate itself. It's going to magnify ER, take away IR. So we should always expect that. Okay, so before you superimpose anything else, whether we're talking about superficial strategies, where we're talking about helical turns and things like that, you got to start thinking, it's like, okay, I'm going to have somebody that's going to be biased towards that. Okay. The fact that you have a reduction in hip external rotation on the left side tells you that you got this guy on a turn. He's a narrow ISA, so he's going to be turning on a more vertical helical axis. So everything fits. As far as what you're seeing in regards to the hip. I think you're dead on point when you look at straight leg raise being more limited on the left side than the right side. Both are limited, which means that he's forward. And if he's a wide receiver, guess what? He should be forward. He's designed to be fast, and so he should be pushing towards late. Okay. And so that accounts for the differences in the straight leg raise. So The only thing that you run into is you've got a little bit of this goes all the way up into his shoulder girdle, into his neck. I don't know if you can see that or not.
Mm-hmm. Yep.
Do you see the IR representation in the shoulder
On the left compared to the right?
Yeah, it's like that doesn't make sense at all, that you should have like crazy IR on one side when you don't have any hip IR on that side. But that
Right.
what that is like he's turning through the neck to create that. Okay.
Right.
So you're dead on as far as all of your turns are correct. All of the late propulsive representations are correct, but keep in mind that he's forward on both sides.
Now,
Okay.
his hip flexion is more limited on the right. Is at 80 degrees, and he has no IR on that. So like when I bring that leg up, is it like adducted? So when am I hitting
okay.
something?
So here he is laying on the table.
Yeah.
Okay. And then here's where you did your measurement.
Yeah.
You see it?
Yeah.
So here's where you measured.
Yeah. Yeah.
Okay. Does that make sense?
Yeah. Absolutely.
Yeah. So here's what you do. So he's over here. Okay. Your first move to get all of his full excursion back is to go that way.
Right.
You see it? Yep. So you gotta move him that way. Don't try to bring this across. Move him over here.
Okay.
Okay. So you're gonna have to move him to his left first.
Okay. So
then you can start to turn him. So here's what's going to happen. So again, if you're measuring here, and so this is his representation, if you try to push him back on the left, here's what happens.
Right.
It all turns to get like you don't get any relative motions back. So you got to move him over first, then you can move him back, and now you have a very powerful strategy to restore what you're talking about. So think about now, let's talk about why he may be still having the discomfort. Does he have full excursion of the knee?
No.
Okay. So you got to start thinking, it's like, okay, what's the orientation of the knee? That's why I'm asking you about the foot, because that's going to give us a lot of information, because we kind of know where the hip and the pelvis are. We just don't know how far forward he is. The foot's going to give us that representation. And so it's like, how low is the arch? What do the toes look like in regards to their behavior? And then that's going to tell you how far forward he is. Does that make sense? So you can see, you say, yeah, he's probably in a late propulsive strategy. Okay. But how far forward is he? And then how far back do you need to actually bring him? All right. Because if he is that far forward, because my guess is, okay, looking at this, when you look at the chessboard and you go, he's only got like a 15-degree deficit in ER compared to the other side. I think it's a heck of a lot more, because I think when you laid him on the table, I think you rolled to the left, and that gave you more ER in that measurement. Okay. Yep. I don't think you should even have that. Right. So again, this is how far forward he is, but the foot's going to give you that information. Now, having said that, you probably got a little twist in the knee. Okay. So he doesn't have a lot of hip IR on that left side as a representation of the hip joint itself, but he's putting pressure into the ground.
Mm-hmm. Mm-hmm.
Now you got to go, okay, where does he put pressure into the ground? All right.
Right.
So if the pelvis did roll back to the left, okay, that means you get a pelvis that is really far forward, anteriorly oriented, more so than we think on that left side, which means that he's trying to turn the hip socket to point downward to create a downward force. IR is down. Remember that?
Yep.
IR is down. ER is up. Okay. So if he's pushing down that hard, where is he pushing down? Chances are you've got an orientation at the knee where he's trying to use the knee to push down into the ground. So you're going to have an orientation problem at the knee. The question mark is again, and I can't see him, but his foot's going to tell you, okay, if you've got more of a lowered arch, okay, you're going to have a femur that's in IR, tibia that's in ER. Okay. Does that make sense?
Tibia is also so his
knee wants to stay extended. His knee wants to stay extended, and then every time you load him and you try to bend that knee, he can't bend it because the orientation of the knee is to keep it straight. Okay.
Got it.
The other possibility, and this is why you want to go to the foot. You got to look at the foot. If he still has an arch, but he's moving towards late, you still have the exact same orientation that I just described in the knee. So you still have a femur that's internally rotated. You still have a tibia that's externally rotated. But then if he's supinated, the whole extremity ER'd on you.
Okay.
And you got a whole different strategy to go after there.
So
you got to bring the extremity back first as a whole, then you can worry about the orientation at the knee. Does that make sense?
So can this be
it's the sequence of events that matters?
So can this correlate with why he has pain or discomfort in like a front elevated split squat with the left leg back?
Oh, absolutely. Yeah.
Okay.
Oh yeah. He doesn't have any IR.
Right. So he's trying to create. It's just ER is an orientation.
So chances are when it's the back leg, is it oriented outward? Yeah.
Outward.
Okay. Yeah. So that's one of your better tells as to what's going on. So now you've got a nice little complex movement comparison that you can use and say, okay, did we recapture what we need to recapture? Put them in the exact same exercise and say, how's it look now? How does it feel now? Right.
Right. Yep. For like interventions or like starting points, what I was doing with him was like rolling patterns to the left.
Too soon.
So
remember what we just said. You measured him over here, right? And if I try to turn him, and as I describe it, he turns like a refrigerator turns. All at one big piece he's turning, right?
Yep.
You've got to create the segmental motion first. Then you can actually get a nice clean turn, because what he's doing right now is he's moving everything together, right? Because he's in late. So you've got a lot of posterior compression. It's like there's not a lot of relative motion that's going on there. You got to create that first. That's why I say go this way first, then try to turn him. Does that make sense?
You got it.
Yeah. Yeah. So he's a narrow dude. So you're going to like short staggers, A to P driven, right? So remember, his helical angle is very vertical. So we don't want to do a lot of like horizontal kind of stuff. You want to keep him on helical angle first, because you're trying to recapture the full excursion.
Yep.
Does that make sense?
Yeah, it makes a lot more sense.
Okay.
Any like even like any ground-based breathing, like hook line? Should I like, what do you suggest there? Like, should I do any hook line, asymmetric hook line exercise?
If you need to take gravity out of the equation, then there's no question that that's what you need to do, right?
Okay.
And maybe it is. Again, I don't know this kid. You know him better than I do.
Right.
And honestly, you may be able to keep him on his feet and do everything. The cable chopping activities and such, unweight him. That might be enough. If it's not enough, like if you don't see your change during your complex comparisons, then you got to slowly take gravity out of the equation, right?
Okay.
Does that make sense?
No, absolutely.
Because I think you're just trying to turn him too soon.
So
and all you're doing is getting orientations. You're not getting the nice little segmental motion. Other than that, I think, like I said, like your diagnosis of what you're representing here is on point. Like you understand that, right? It's just your intervention sequence. But I think that one, get a peek at his feet, so you know how far forward he is. You know how you need to orient the whole lower extremity first, then go after the segmental motion, or do you just have to go after the segmental motion at the knee? And I think you could probably alleviate it. So heel to butt is going to be your knee measure, right?
Yep.
Does he have full extension? I would think he's got full extension.
I haven't tested it, so
okay.
Test it.
All right. Well, so the two big tests for me for knees, like I don't do special tests. I just look at the ability to extend the knee and then heel to butt measure, because that's going to tell you what your orientation of the tibia is relative to the femur. Those are the most important measures that you've gotten in regards to the knee. Make sure you have those, because again, they're very telling, because they're going to let you know that you got the orientation correct.
Right.
Worst case scenario, the guy that was just on the video a minute ago,
yeah,
stuck his face in there.
Yeah,
okay.
Guy.
right?
Yeah, yeah.
Worst case scenario, you call him in to lay hands, okay? But that's
I see him every day, so yeah,
okay.
I got him.
I'm sorry to hear that. I'm sorry to hear that.
Yeah.
It must be really difficult for you to come into work every day.
Yeah. That's a good dude.
All right. Do you have any other questions, young man?
No, I'm all set.
Okay.
Thank you so much.
Awesome interpretation. You are on point with your interpretation. Like I said, just play with the sequencing a little bit, get a little bit more information in regards to the foot position. Okay.
Okay. Thank you, Bill. Appreciate it.
Have a great day.
You too.